Children with endocrine disorders. We treat a lot of them. There's two types of hormones in the endocrine system. Peptide hormones, like a glycoprotein or a modified amino acid. They have to have a carrier to get into the cell. And then there's also steroid hormones, like lipids. They are lipid in form, estrogen, progesterone. They are water-insoluble lipids, and we don't digest them well. The organs or tissues are the hypothalamus, pituitary gland, thyroid gland, parathyroid gland, adrenal gland, testes, ovaries, and the islet of Langerhans. The problems that arise are related to whether or not there's too much or not enough of a hormone. And this can lead to delayed growth and development, cognitive impairments, and or death. Some differences between an adult endocrine system and a pediatric endocrine system is that the hormonal control of the body functions doesn't really occur until a child is 12 to 18 months of age. So, the main neural control center is your hypothalamus. We call it the master gland or the switchboard. I want you to look at this picture and look at all the different hormones that are released by the different sections, the different glands. So the posterior pituitary secretes ADH, which is antidiuretic hormone. Antidiuretic means we don't want you to pee. Oxytocin is another thing that the posterior pituitary does. Your anterior pituitary secretes TSH, adrenocorticotropic hormone. We also call that ACTH. Gonadotropin hormone, FSH, LH, and prolactin. These are all related to growth and sex hormones. Your thyroid, it's T3, T4, and calcitonin. Calcitonin does what? It lowers your calcium in your blood. Your parathyroid secretes parathyroid hormone. Funny that. Adrenal cortex, it secretes glucocorticoids, mineralocorticoids, and sex hormones. Your adrenal medulla secretes epinephrine and norepinephrine, and your pancreas secretes insulin and glucagon. So a feedback control is when one gland produces a hormone that affects another gland. And then the target organ then stops the further release of the original hormone. So it's kind of like going back and forth in a little loop. This is negative feedback and positive feedback. So I'm not going to get into the pathophysiology of this. I just want you to know that a good example of a negative feedback loop is regulation of your blood calcium levels. So your parathyroid secretes the parathyroid hormone. It regulates blood calcium amount. So if your calcium levels decrease, the parathyroid says, oh, it's decreasing, and then it spits out more parathyroid hormone. Then the parathyroid hormone stimulates the calcium to release from the bones, and that increases the calcium uptake into your bloodstream. This is all occurring in the kidneys. And then the same thing happens if you have too much blood calcium. The parathyroid gland is going to reduce its production of parathyroid hormone. It stops spitting it out. So both of these, whether it's doing more or doing less, it's still a negative feedback loop, because the effects are negative or opposite to the stimulus. It's hard to wrap your brain around. Positive feedback loops, the best example is childbirth. So a positive feedback loop is one that promotes the original stimulus. It doesn't want to stop it. So your body's just going to keep promoting what's causing the contractions until a desired effect happens, which is birth. So most positive feedback loops, well, I think the only other positive feedback loop that we'd see would be death besides birth. So growth hormone deficiency, you can find information about it on page 1782 in your text. So the incidence is that it affects 1 in 4,000 children, and some of the manifestations that we might see clinically is that you start looking at the growth patterns of your infant, and they started out with a normal birth and birth weight and length. And then within a few years of life, they are less than the 3rd percentile. So they might be 50-50. They might be in the 50th percentile at birth for weight and length. And then by the time they've hit 2 years old, 97% of the population is taller and bigger than them. Way more, all of that. They develop hypoglycemia. We also call growth hormone deficiency hypopituitarism or dwarfism. Your growth hormone is required for linear growth of your bones. The mineral density and all of your body tissue growth is stimulated by growth hormone. And we secrete it throughout the day, and then there's a whole lot of secretion while we're sleeping. And this is part of the reason why infants sleep so much. Maybe it's why I sleep so much, because I am just growing and growing and growing. Pathophysiology of this is that there's a failure of the anterior pituitary on the pituitary to produce growth hormone. So then without the growth hormone, the body can't metabolize proteins, they can't metabolize fat, they can't metabolize carbohydrates, so they don't grow as well. Some of the therapeutic managements is we provide supplemental growth hormone. There's one that's called somatropin. It's biosynthetic. It stimulates the linear bone growth, skeletal muscle growth, and organ growth. We can give it subcutaneously every day, and we'll continue this treatment until they get to the height that we think they should be at that age. The nursing implications of this is that we have to monitor their blood sugar and their electrolyte levels pretty closely, and we have to educate the family on how to administer it, because they're more than likely going to be doing this at home themselves. So we're going to go through, hygiene and aseptic technique and how to give an injection, how to draw it up. These kids will have, when we look at their bone age on a scan, there'll be 2 or more deviations below normal. So they might be a 16-year-old and they might be showing a bone age of like 12. Their CT or MRI will be done to rule out tumors or structural abnormalities that could be causing the growth hormone deficiency. And then a pituitary function test confirms the diagnosis. We're going to give insulin, clonidine, glucagon. We're going to do serial blood samples at specific times. We are going to, when we manage them, try to promote growth at least 3 to 5 inches in the first year of treatment, and we're going to plot their growth every 3 to 6 months on the growth charts. If we diagnose and treat them really early, they have a really good prognosis for reaching a normal adult height. We stop treatment when their epiphyseal growth plate fuses. And then we also want to enhance self-esteem in these children. We don't need people who are smaller in stature to feel poorly about themselves. So we need to allow the child to express negative feelings, but also to express positive feelings about themselves. And then there's support groups. There's literally a foundation for human growth, and there's a foundation for short stature. We can get the families involved with other families that deal with the same diagnoses. We're going to educate the families on medication administration, when they need to contact a physician or come back to the clinic, and the need for routine follow-up. And then we can help them. Usually case management or social work is going to help them obtain financial assistance for the growth hormone therapy because it can be expensive. Okay, congenital hypothyroidism is a malformation or a malfunction of the thyroid gland. So they have insufficient production of the hormones. This one's affecting T3 and T4 hormones. It occurs in 1 in 2,000 to 4,000 live births. Some of the complications are intellectual disability, short stature, growth failure, and delayed physical maturation and development. To diagnose congenital hypothyroidism, We do newborn screening, which they're showing in the little picture here. They fill up little circles with heel blood and send it off to the state. We look at the T4 levels, which are usually low, and the TSH levels, and we can do a thyroid scan. Therapeutic management. We want to normalize their thyroid function as quickly as possible. We do hormone replacement therapy with levothyroxine, which means we have to check their blood pressure and pulse before each dose. We measure their fluid intake and output very closely, and we do daily weights. We need to let the doctor know if they are irritable or anxious, because that can indicate toxicity from the levothyroxine. We need them to avoid iodine-containing foods like soybeans, salt, tofu, and turnips. They can have regular salt, just not iodized salt. And we need to tell the parents to give their meds at the same time every day. We're going to monitor their thyroid function tests pretty closely for the first year of life. Every 2 weeks, and then until we reach the target range for the levothyroxine. And then after that, it's every 1 to 2 months until they're 6 months old, and then every 3 to 4 months from 6 months to 36 months of age. And then after that, we do it every year until they've completed their growth. We want to watch them for signs and symptoms of overdose, which is irritability, rapid pulse, dyspnea, sweating, fever, or undertreatment, which is fatigue, constipation, and decreased appetite. And we're going to educate the family about how to give the medication. They can crush levothyroxine and mix it with a little bit of formula. We want to tell them about the adverse effects and that the child needs to be on this med for their whole life. Juvenile Hashimoto syndrome, also known as acquired hypothyroidism. Ooh, we finally got one that happens more often in girls than boys. More often in females than males, occurs during childhood and adolescence, and it peaks at puberty. Sometimes it requires treatment, sometimes it's self-limiting. The pathophysiology of this is that there are autoantibodies that are circulating around, and then they bind to receptors on the thyroid gland, and then there's infiltration and inflammation that then leads to fibrosis and scarring, and the thyroid is unhappy. Some of the manifestations are that they are going to have a decreased rate of growth. They can develop a goiter, which is like a big, huge, swelling, swollen, enlarged thyroid gland on the side of their throat. I'll try to attach a picture on the board. They're going to have weight gain with very little appetite. They're going to develop constipation. They're going to have dry skin, thinning or coarse hair. Sometimes you'll see women that have a lot of balding, and that's usually due to hypothyroidism. They're going to have edema of the face, eyes, and hands. Delayed deep tendon reflexes, delayed puberty. The way we diagnose acquired hypothyroidism is through TSH, T4, and serum thyroid antibody tests. And then we can do a thyroid uptake test with an MRI, and that shows us the overgrowth and scarring. So if they develop this syndrome or disease in a third world country, they can be treated with iodine therapy. Usually in third world countries, they don't have iodized salt, and it can lead to thyroid disease and goiter. Here, we tend to develop thyroid disease and goiter for other reasons than lack of iodine. We can treat them with thyroid hormones. It's basically the same treatment that we would give to someone with congenital hypothyroidism, so levothyroxine. The nursing diagnoses. I don't care that you know any of these, but they're like delayed growth and development related to blah, blah, blah. Hypothermia, constipation, activity intolerance, because they're going to have fatigue. They're going to have decreased endurance levels. The actions that you're going to take when you're dealing with children with acquired hypothyroidism is to manage their hormone levels as best you can by monitoring their blood and their medication intake and checking for, again, signs of overdose from levothyroxine, which are what? Graves' disease or hyperthyroidism is due to excessive levels of circulating thyroid hormones. This usually occurs in adolescence, and it's an autoimmune disorder. The signs and symptoms are usually overlooked because they tend to kind of go along with being an adolescent. So problem sleeping, bad school performance, distracted. They're often distracted. They're emotionally labile. They might have insomnia. They get frustrated really easy. They hate PE class because they get too hot and too tired. Is this not literally every adolescent? But then we throw in diarrhea, excessive perspiration, muscle weakness. And these kids will have a really big appetite, but weight loss. They'll develop tachycardia, tremors. They have bulging eyes, which is otherwise known as exophthalmos, and their blood pressure will be elevated. So I want you guys to tell me, their TSH is low. What do we see in their T4 and T3? We give these children methimazole, which blocks T3 and T4. We treat them with radioactive iodine therapy, long-term until their thyroid is what we call ablated or destroyed. We use propranolol and atenolol if they have really marked symptoms, and we can do surgical management with a subtotal thyroidectomy where we're just kind of removing a large portion of it, but still leaving some behind. They'll still have to be on medication. We want to educate parents about the medication and the side effects, and that they need to follow up pretty much for the rest of their life. Congenital adrenal hyperplasia. This is a recessive autosomal inherited disorder. There is not enough cortisol and not enough aldosterone floating around in these kids. It's not as common as some other illnesses we've talked about. It's 1 in 15,000 to 20,000 live births. This is life-threatening, and if they're not diagnosed at birth with newborn screening, they probably will die. The complications of congenital adrenal hyperplasia are hyponatremia, hyperkalemia, hypotension, shock, hypoglycemia. If they do live to be adults, they're going to have short stature, and very often the males will develop testicular tumors as adults. So the pathophysiology of this is rather confusing as well, but basically they have a prolonged oversecretion of ACTH, which causes the adrenal glands to become hyperplastic, meaning too much growth. Then they produce excessive amounts of androgens. So the male characteristics might occur really early here. In the males, they're going to have an enlarged penis. They might have precocious puberty at 2 to 3 years of age. And in the females, we're going to see what we would consider ambiguous genitalia, or genitalia that you can't really pinpoint when they're an infant, if it's a female or a male. They're going to exhibit aldosterone insufficiency with fluid and electrolyte imbalances. Part of the reason why this is a life-threatening illness is because of the hyperkalemia and hyponatremia, which acts on what? Their heart's ability to function. And then cortisol insufficiency in these children leads to hypoglycemia, and hypoglycemia as an infant can also kill you. The goal of treatment is to stop the adrenal secretion of androgens. We treat them with lifetime glucocorticoids such as hydrocortisone, and then we also give mineralocorticoids, which are the fludrocortisones. If you're giving the right dose over their lifetime, there shouldn't be any need for adverse side effects monitoring, but an inappropriate dose can cause some issues. So they need to have regular follow-up throughout their lives to be able to assess them for the appropriate level of growth and development, because sometimes these doses have to be titrated. When we're managing them, we need to teach the family the importance of the medication and why they have to have really tight control over the dosing. We're going to teach them how to give IM hydrocortisone if the kid's sick, because if we give them the oral hydrocortisone, they are likely to puke it up or not absorb it. So unfortunately, they have to get shots when they're not doing well. If they're under stress, they might need additional doses of cortisone. And we want them to wear one of the little medical ID bracelets or have some sort of identification indicating that they suffer from this. And we want to give the family support as best we can, so we get case management and social work involved. This is a big one. So type 1 diabetes. They used to call this juvenile diabetes. They don't anymore because they're fighting adults that meet the criteria for diagnosis of type 1. So the incidence is every year we get approximately 13,000 children and adolescents that are diagnosed with type 1. Under 20, we see upwards of 200,000 kids every year diagnosed with it. In the pathophysiology, we're looking at a deficiency of insulin secretion because they have B cell damage in the pancreas. Those live in the islet of Langerhans. It is considered an autoimmune disease. It's not necessarily related to your familial structure. So you could have been exposed to a virus like chickenpox or any of the other constellation of massive amounts of childhood viruses, and it messes some things up in your pancreas, and then you develop type 1 diabetes. So it's not always something you're necessarily born with. It's a deficiency of your insulin. They don't work as the gatekeepers for your glucose to get into the cell. So you develop hyperglycemia in the bloodstream. The kidneys then try to lower your blood glucose, which results in sugar and spilling into the urine and protein spilling into the urine and fat being broken down for energy, which leads to wasting. And then you also do see the 3 Ps, the polydipsia, polyphagia, polyuria in these kids as well. Because they're metabolizing fat, it leads to a buildup of ketones and acidosis, which leads to diabetic ketoacidosis. When we're looking at the labs, we're going to look at the A1C. If it's greater than 6.5, we're probably on the right path. They're going to have random glucose levels higher than 200 milligrams per deciliter, and their fasting blood glucose level is going to be greater than 126 milligrams per deciliter. Some of the complications they're going to develop are the same that we see in type 2 diabetics in adults. There's damage to the microvascular structures, the blood vessels and the nerves. They have eye involvement, kidney involvement, brain involvement, heart involvement. Long term, they're going to have failure to grow. They might have delayed maturation sexually. They might have poor wound healing if they're not in good control. They're going to have recurrent infections and all of the same things that I just said that you would see in an adult. Another complication is diabetic ketoacidosis. It's based on fat catabolism. So they develop anorexia, nausea, vomiting, altered level of consciousness, and abdominal pain, kussmaul respirations, which I put a video on the board of that. 2 of them actually, so that you can see it, and one that you can hear it. And we can also see complications of coma leading to death. So when we are managing these children therapeutically, we're treating them usually on an outpatient basis once we've gained some control during a hospitalization. If it's a first-time new diagnosis patient, we need to have them in the hospital to get control of their glucose and to educate the family appropriately. And then thereafter, they're managed as an outpatient unless they have an episode of DKA. So some of the goals that we look towards are achieving normal growth and development, making sure that they understand how to keep their glucose under good control, when they need to monitor their blood glucose, and giving good education on how to monitor when the child is sick or not feeding well or starting to exercise because they're playing sports or participating in PE. We need to monitor their A1C levels as well and keep them below 7.5 to avoid the microvascular diseases or complications that we can see with this. And we want to try to promote the child adjusting positively to this and not necessarily treating it as something that makes them super different. And we need to get the school involved in the care of the child as well. And social work and case management will help a lot with that. So these kids are going to do the same sub-Q injections as a normal, not a normal, but as a type 2 diabetic might, or an adult diabetic that's using insulin. We do want to try to move more kids into using insulin pumps because it is less stigmatizing. We need to teach them how to rotate their sites so that they don't develop the adipose hypertrophy, because I've seen that and it is really pretty marked in a person that you can tell they just didn't want anybody seeing them injecting their insulin, and they're doing it in the same spot right underneath where they can lift their shirt up at school, standing in front of their locker, and then they get this huge lump there that stays for the rest of their life. You guys need to write down your onset, peak, and duration for all your different insulins. So Lispro is rapid, it's 5 to 15 minute onset, 30 to 90 minute peak, and it has a duration of 5 hours. Regular insulin, write that one down as well. It's a short acting. We do like to get these kids on Glargine or Lantus, which is a long acting. It has no peak and it lasts for 6 to 24 hours. This is going to give us better control over their basal insulin levels. When we're managing the complications, these kids need to have eye exams annually until they're 10 years old because we're searching for retinopathy. We want to have annual screening for microalbuminuria from the time they're 10 years old and or have had diabetes for 5 years because we're searching for nephropathy. We want to also screen them for celiac disease and hypothyroidism every 2 years at least, because these are commonly associated with diabetics. We need to teach them how to use glucagon for severe hypoglycemic reactions and make sure they have that at home at all times. We need to make sure that they have glucose paste or tablets that can be used. And we want to teach parents how to monitor for DKA. When they're in the hospital with DKA, we're going to monitor their glucose level every hour. And because if they get too low too quickly, it can cause cerebral edema. So when you have them on an insulin drip, we don't want to see their glucose level fall more than 100 milligrams per deciliter in an hour. That's the magic number that we want to watch for to indicate they could be at risk of developing cerebral edema. We're going to give them insulin in the IV, bolus doses of 0.1 unit per kilogram and then 0.1 unit per kilogram per hour. We give them fluid therapy to control and correct the electrolyte imbalances that they're going to have. I'm going to tell you one thing. Parents are really big about, oh, we need to feed them, we need to feed them, we need to feed them. When you've got them on insulin drips, the second you start feeding them, if a doctor orders a diet, advocate for yourself as a nurse and ask for orders for sub-Q rather than a drip or IV insulin, because you're going to be chasing their glucose all over the place if they're eating. So it's a mess. It is like a every 20-minute kind of thing. So they don't eat when they're on an insulin drip. In the education department, we're going to teach the family and the kids how to monitor their glucose. We're going to give sick day instructions that they have to check more frequently and have ketone strips for urine dipsticks at home so that they can check to see if they're spilling protein in their urine and maybe need to come to the hospital. We're going to teach them how to use a sliding scale to calculate their insulin dosage. I know that a lot of people this semester missed a lot of your med math administration med surge tests based on insulin. And in the peds area, it is so important. So bone up. We're going to teach the family about diet and exercise. They have to learn how to identify carbs, proteins, and fats. And they need to have 3 meals and snacks. And most of the time the rule is they can have snacks that are between 15 and 30 carbs throughout the day. And if they're exercising, they can add an extra one for every 45 to 60 minutes of exercise. There are 2 different types of diabetes insipidus. There's one that is nephrogenic and one that is central. We're really only going to discuss the central one. So central diabetes insipidus is caused by the posterior pituitary gland not functioning appropriately. They've developed some type of head trauma, or it has developed because of head trauma, or they have meningitis or encephalitis or a type of cancer. Possibly they've had drugs like phenytoin, which I believe we use in seizures, and it can cause diabetes insipidus. 10% of central diabetes insipidus are idiopathic, which means we just don't know. They are, however, usually permanent and they have to be treated throughout their whole life. The manifestations of this is that they have excessive thirst and excessive urination. So you see 2 P's, not 3. In the labs and diagnostics, we're doing CT scans, MRI, and ultrasound just to look for tumors or damage. And then we want to look at the urine-specific gravity. It's not super specific to this disease. And we want to look at their serum sodium levels. If it is elevated in the blood and low in the urine, usually diabetes insipidus. We do a water deprivation test that takes about 7 to 8 hours. We weigh a kid, and then we start depriving them of water. Then we weigh them in the middle of the 7 to 8 hours. We're still depriving them of water, and then we do it at the end. We weigh them again. Urine osmolality and outputs measured, and we stop this test if they lose 3 to 5% of their weight, which you'd be surprised it happens. We also stop the test if they have any neurological changes or marked changes in their vital signs. The pathophysiology with this is very involved. Basically, we're just looking at there's not enough ADH being secreted by the hypothalamus, and then the kidneys reabsorbing water, and they retain sodium in the serum but lose tons of water. When we manage these kids, we're replacing antidiuretic hormone in the older kids with a medication called DDAVP. We give this in injectable form, usually sub-Q. It says you can give it intranasally. I've never done that, and I've also never given it orally. We titrate the doses of DDAVP based on how old they are and their urinary output. We monitor these kids for water intoxication, hyponatremia, nasal irritation, headaches, nausea, hypertension, and we're gonna instruct the family and the kid to keep the medication in the fridge. If they're gonna use the nasal form of it, they have to blow their nose before they administer it, because otherwise they're not going to absorb what they need to absorb. If the child sneezes when you're giving it, that you need to repeat it, because you basically just lost all of it. We're going to measure urine-specific gravity, and we're going to avoid over-the-counter cough and allergy medications because that decreases the response in the body to the DDAVP. In infants, we do treat them with fluid therapy. So we want to promote rehydration. The goal is 1 to 2 mLs per kg per hour of urine output with a specific gravity of 1.010. We want to educate the family about developing a regimen on how much the child needs to drink and what water intoxication versus dehydration looks like. We also want to educate their teachers because these kids are going to need to go to the bathroom a lot. They are just literally just urine, 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 urine. You'll take a diaper off a 3-month-old that weighs like 400 every hour. It is crazy. They need to have medical ID alert bracelets, and they need to follow up at least every 6 months. So part of the reason why this is called insipidus, where our other diabetes is called mellitus, insipidus means lacking flavor, and mellitus means sweet. It doesn't mean that you're sweet if you have diabetes mellitus, like you like to eat candy. It's because back in the day, the doctors would actually taste the urine to see what illnesses they thought you had. So they did realize over time that with diabetes insipidus, the urine tasted dull and gross, flat, and with mellitus, it was sweet and fruity. Nasty.